Good afternoon. I just wanted to welcome everybody to this CT Forum afternoon session, which is looking at quality and service improvement. And this session has been sponsored by Consent to Patients, who look at basic digital consent process on a virtual platform. Our first speaker I'd like to welcome is Martin Stones. He is going to talk on altered states in intensive care. There are a presentation of images of the hallucinations described by post-cardiac surgical patients. And I'd like to finally also welcome my other co-chairs who you'll see at the end of this session, who are Rakesh Arora from Canada and Jenny Palimi from the UK.
Hello, my name is Martin Stones. I'm a PhD student studying delirium. Patients who hallucinate describe their experiences to our hospital artist, Jan Sharp. These are the images that she's produced. I hope you find them insightful. This patient thought he was in a film called the Delirium study. He could see the credits roll up in front of his eyes. Note the Father Christmas. This wasn't a real Father Christmas, he was an imposter. Eyes distortions like Alice in Wonderland. The patient became distressed as the clinicians got smaller and smaller and left through a tiny door in the corner. Note the importance of the monitors to her. Nurses in funny clothes were embalming the dead lady in the bed opposite. This patient didn't go to bed for the whole of his ICU stay. He said, "I'm not going to bed, they might do that to me." This lady cried with relief when she told me about these pink clouds. She said that she thought nobody would believe her. The common theme is being looked at or being on show. This patient thought he was in the middle of an opera house. I looked up at the ceiling and it shattered. The portable X-ray machine was laser beaming me, just like in the James Bond film. A benign old man at the end of the bed. Grim Reaper, perhaps. A void at the end of the bed reminds me of a crematorium, or perhaps a waste disposal unit. Described as the gates of hell. I never want to go there again. Persistence of vision and tactile hallucinations. The bed is shaking. Comforting mural on the wall, a common theme. Simple and complex hallucinations. Lightning, smoke, and flashes of light. Note the faces of the dolls in the plug sockets on the wall. There was a child's tea party on the bed opposite. I was feeling a bit peckish, so I crept over and tried to grab one of the sausages. But as I did so, it turned into a pair of glasses and I knew I was hallucinating. That's one of my favourites. Chaos. Cats and dogs running around the ward. The best experience of my life, Doctor. What, having your chest cracked open? Yes, Doctor, it was wonderful. I wonder if this is something to do with the morphine. The ICU door burst open and a growling, drooling dog put its head through. That woke the patient up with a start. An avalanche of brightly coloured bubble cars. Pareidolia, an alien animal on the cliff face. Being flung into space by a comet with eyes. Scary birds at the end of the bed. The ICU wall became a window on the world, a savannah with birds flying and deer running. Doctor, doctor, the nurses are trying to kill me. I can see you're distressed. I'll keep an eye out for you and come and see you in the morning. Yes, I'm still alive. That's what it's like on ICU. You're stuck on your back in a pit. You can't move. There's pipes and tubes everywhere. Your lips are sore and dry. That's what it's like. Falling, falling, falling. This is not an hallucination. This is a near-death experience. The patient was unconscious for about 10 minutes while he was being defibrillated with a VF arrest in the field. I hope you found these images offer some insight into the patient experience. I would like to thank the patients, the cardiothoracic unit, and Dr. Balachandran, the principal investigator. Thank you.
Thank you, Martin, for that fascinating presentation that you gave us. So I'd just like to invite everybody, the chat is open, so if you've got any questions that you'd like to ask Martin, please feel free to put them on the chat so we can ask the questions. Don't think there's any at the moment, so I'll just ask Martin a quick question. Martin, those pictures are amazing. Do you have a psychologist or anybody that can come and talk to the patients about the pictures and what they mean and how you can progress?
No, we haven't done that as yet. We don't have a psychologist on the cardiac ICU. They do have one on the main ICU. What we're intending to do is we've got some funding from the British Geriatric Society to produce a 60-page picture book. We're going to make a prototype of 200 and put them around the wards of the hospital for both students and clinicians and nurses sort of education and healthcare assistants education, but also we may use it for patients. We'll have to see how it goes, to show patients and their families if there's some problem. And we found that sometimes showing pictures to the patients does sort of normalize things and they're worried about it. But once you explain that it's not unusual, many settle down.
No, I think that's right. I think if you show the patients beforehand and say, look, this is the kind of things other people have experienced, then when they have that kind of experience themselves, then they're not panicking that it's something that's unusual.
Yeah, so we'll have to see how it goes. So I have a couple of questions from the Slido here, Christina and Jenny, for you, Martin. One, I think you've answered with regards to how would these be published, and really incredible images, and it sounds like you're going to put together a book. The other question I have here from Simon Kendall is, what's the average length of such hallucinations? Do they last one night, 2 nights, many days?
Okay, that's an excellent question. And that's what my PhD is about. I'm looking at the biochemistry of delirium. This is just a sort of opportunistic sideline which popped up when I found out that so many patients were hallucinating. The literature says day 2. So patients wake up, they're pretty good the first day, they're obviously tired. Day 2, it's thought that there's some association with their CRPs and cortisol levels, which seem to rise on the second day. And then that's when the most problems, the paranoia, the hallucinations, hearing things, will peak. And then as the CRP goes down and the white cell count goes down, they come back to normality. Days later, if there's a secondary infection, like a chest infection, because they don't get up quickly enough, then there can be secondary episodes of delirium. I have to say, I've seen most delirium is on day 2, but I have seen delirium on day 1 and have seen it on day 3 as well. And it normally lasts, it's usually quite transient and usually lasts less than a day, but it can go on for, I think the most would probably be about a month.
So just if we have time for one more quick question along the same lines, when the patients can comment on either those images which are perhaps a bit more pleasant versus those ones which are a bit more horrific, how have you found the staff's, like the ward nursing staff and others' reactions to those? Are they different?
Generally, people just find it fascinating and are not generally upset by them. The only person I could say who's been upset is my lab, the professor in the lab. She gets really upset by them and it really puts her off going to, she hopes she never goes to hospital. I think the biggest thing I've found is that it's very, very difficult to detect that people are hallucinating when they're on the ICU. And I've carried out a retrospective questionnaire called the Altered States, which looks back, and about twice as many people tell me that they're having hallucinations. The only thing we're good at picking up is paranoia. We're spot on with that. The reason, I don't know. Lack of insight, not wanting to get involved in it, too tired, scared that they may be sent to the lunatic asylum. Who knows?
Great, thank you.
Many thanks, Martin.
Thank you.
Okay,
Pleasure.
that's great. Thank you. So our next speaker is Daisy Sandeman. She is going to present her study looking at exploring delirium following cardiac surgery. And just to add, Daisy is a lead AMP and is actually the SCTS CT Forum meeting organizer. So welcome, Daisy.
Hello everyone, I'm Daisy Sandeman. I'm here to talk about postoperative delirium. I'd like to thank the Society for giving me this opportunity to present today on this platform, and also the virtual audience for attending this session. For me, it all came to light in 2014, where I was quite taken aback by the incidence rate of delirium in our center. It accounted to about 40 to 45% that particular year. According to Diagnostic and Statistical Manual of Mental Disorders, delirium is an acute onset syndrome with disturbance in attention, awareness, and cognition. There are three types of delirium: hyperactive, which is very well known, people notice it; hypoactive, which is quite often missed; and the mixed form of delirium. The delirium experience, according to patients' anecdotes, range from visual and auditory hallucinations to very overt, violent and aggressive episodes, and sometimes it gets misinterpreted to early signs of dementia. My PhD journey started in 2015, and the research question was done in the form of a mixed method study to identify the incidence of post-traumatic stress symptoms in patients with delirium following cardiac surgery. Data collection happened in three different phases. Phase 1 had baseline data, including questionnaires, which were hospital anxiety and depression score, 10-item personality inventory, and 4AT, which is a screening tool for delirium. 406 patients participated in this study, of which 18% developed postoperative delirium. They were followed up in a 6-week clinic, and I repeated the hospital anxiety questionnaire along with post-traumatic stress symptoms, structural clinical interview, and 4AT to again screen if there was any ongoing delirium. 16 patients are followed up in phase 2A of the study, where in addition to all the others, I also added a semi-structured interview to identify what the experience of delirium was like for the patient. Medical Research Council framework for evaluating complex intervention was used for data analysis. The quantitative data included happened in 3 phases: preoperative, intraoperative, and postoperative phase. And the quantitative data analysis showed that age at time of surgery and renal function were the 2 most important factors identified, which would help identify patients at risk of delirium. Renal function was a univariate covariant, whereas the multivariable regression model showed that age at time of surgery was the only significant risk factor. The hypothesis of post-traumatic stress symptoms was proven null, as only 2 patients had heightened anxiety at their 3-month follow-up. The qualitative data analysis was very interesting. It showed that many patients didn't have any recollection of the event. Even if they did, when they were told about it, there was a lot of apologies, and if they were asked what was their emphasis on during the recovery process, it was all about the physical recovery. They were given if they were told if they were given the option of knowing what they know now, would they still go ahead and have the operation? And 100% of the patients said they categorically would. They were all reassured that someone was following them up, not only to find out about their physical recovery, but also their emotional and cognitive recovery following implications of findings are varied. It would be good to identify patients at risk, that is not only the age, but also the frailty factor. Informing patients of all sorts of complications, including such complications, because when they do happen and they're informed about it, the level of distress is much controlled. Optimizing these patients before surgery in terms of possibly using enhanced recovery principles like reducing fasting times, hydration, nutrition, prehab, also reviewing of polypharmacy. Comprehensive follow-up includes not only physical follow-up of symptoms of physical recovery, but also emotional and cognitive recovery. And if patients do develop any psychological sequel, then making sure that they have enough support system before they get discharged into the community. I'd like to extend my acknowledgements to the following, and thank you again.
Thank you, Daisy, for that. That was the great presentation again. Have we got any questions at all from chat, Rakesh?
Nothing at the moment.
Okay. Any questions from the panel?
I wouldn't mind asking one. So, Daisy, you mentioned the preoperative risk factors being age and renal dysfunction. What about home living status and psychosocial sort of constructs, those who live alone versus those who perhaps don't? And you mentioned frailty as well. How do you think those interact with the postoperative rates of delirium in your patients?
Thank you, Rakesh, for the question. In this particular study, I didn't include those two factors when I first began looking at the factors which were quite relevant. At that point, the physiological factors were the ones that we could anecdotally see were causing a lot of implications on the incidence. But through the course of my 5 years, looking into delirium much more, I think frailty is definitely one more factor that has to be highlighted. And we're taking that into account, especially because patients with valve undergoing surgery have a higher incidence in their univariate analysis. So it would be important to see if frailty can be identified and a social platform created to make sure that they have some kind of follow-up if they do develop delirium following surgery.
Great. We have one more question from the Slido here from Simon Kendall again. Thank you for this question. So thank you for your presentation, Daisy. What are the key things that we as doctors and nurses can do for the patients? Any tips on how we can communicate these problems with their relatives?
Thank you, Simon. I think the most important thing is not waiting for delirium to happen, education, and not only for the healthcare professionals, but also the patients and their family. We proactively meet patients before surgery at a pre-admission clinic. And since we have got delirium talking, we include that as an important education material to discuss so that patients know what to expect if such an event happens. And even if they are unaware, the family will highlight it to the healthcare professionals that their loved one is not the same as they would have been before surgery. This empowers them and gives them control, and this lack of control also attributes to them feeling helpless. But knowing what's happening and it is going to come to an end is very reassuring. So I think I would start with that.
Great, thank you.
Many thanks, Daisy. Thank you very much for your presentation.
Thank you for having me.
I'd like to welcome us to the presentation. He's going to present on recovery from intensive care unit acquired weakness following an aortic valve surgery, the effect on muscle mass, function, and quality of life. Welcome to Ashley.
Good afternoon. My name is Ashley Thomas, and I am here to present our abstract based on part of my PhD project in association with Barts Health NHS Trust, Queen Mary University of London, and generously funded by Barts Charity. The title is Recovery from Intensive Care Unit Acquired Weakness Following Aortic Valve Surgery, the Recovery Trajectory of Muscle Mass and Health-Related Quality of Life. As we know, intensive care unit acquired weakness is a debilitating condition associated with increased mortality and morbidity and known to have a significant impact on recovery and resources. We used a subclinical cardiac surgical model focused on aortic valve replacement specifically to investigate this further. Previous research using the same model have already established that significant muscle loss occurs in the first 7 days post-surgery. However, no studies have looked at how this muscle loss recovers between hospital discharge and follow-up. Therefore, we sought to investigate the effect of cardiac surgery on muscle mass and function at 7 days and 6 weeks after surgery, and the effect on health-related quality of life, anxiety, depression, and reintegration into society. Unlike other research, we also measured both the dominant and non-dominant limbs to establish a trend. However, due to the tightness of the results, I'm going to focus mainly on the dominant limbs today. It is important to understand, however, that the dominant and non-dominant limb were equally affected and produced the same results as established with our correlation coefficients. The image shows a flow diagram of the whole of the project, but encapsulated in the blue borders are the methods that I'm going to specifically talk about today. Muscle size assessment was measured using B-mode ultrasound of the rectus femoris cross-sectional area in the musculoskeletal mode, and that is because the rectus femoris is the only quadricep muscle that can be encapsulated in one image, and the fact that lower extremities waste more rapidly than upper extremities. Function was assessed using the short physical performance battery, and questionnaires used were the hospital anxiety and depression scale, the EQ5D5L for health-related quality of life, and the reintegration to normal living index. The results of the rectus femoris cross-sectional area are shown in the two graphs here, A and B, representing raw data and normative data respectively. Now, patients lost significant rectus femoris muscle bulk in the first 7 days after aortic valve surgery, totaling 6.5% or 0.2 centimeters squared. Now, dissimilar to our hypothesis, muscle wasting actually continued between the preoperative assessment and outpatient follow-up, totaling 10.14% or 0.32 centimeters squared. We had 31 patients attend preoperative and day 7 hospital discharge, and unfortunately, due to COVID, we had 22 patients return for follow-up. We measured function using the short physical performance battery, and how this compares with RFCSA is interesting. So the short physical performance battery decreased from a median of 11 to 9 in the first 7 days post-surgery. However, dissimilar to RFCSA, patients were actually seen to recover their function from a median of 9 to 12. So they increased their function or recovered their function, dissimilar to rectus femoris. EQ5D5L can be split into two sections. First of all, the visual analog scale, where patients reported that their scores increased by 11.71% between day 7 hospital discharge and by 10% between preoperative assessment and follow-up. And that's a difference between 80 and 90 out of 100 indicative of the best health possible. Overall, Crosswalk Index reiterated this finding by showing that there's an increase of 27.9% in the 5 parameters and 17% between preoperative assessment and follow-up, suggesting that patients feel better as a result from the surgery. Anxiety and depression, the anxiety levels were non-significant, although reduced between preoperative and follow-up, and depression scores were significantly decreased between day 7 hospital discharge and follow-up and baseline and follow-up. However, the clinical relevance of this is little, and that is because all the values were below 7, which is considered normal. Now, due to patient-reported reintegration to normal living index scores being high preoperatively, it left no real scope for improvement, and therefore there was no significance found between the time points. So in conclusion, patients undergoing surgical aortic valve replacements lose considerable RFCSA in hospital and continue to do so until 6 weeks after surgery. However, this does not appear to impact recovery, as function significantly improves from day 7 to follow-up, and patients' health score, function index, and depression scores also improve. I thank you very much for listening to my presentation, and I invite any questions. Thank you very much.
Ashley, just like to say thank you very much for your presentation. Again, another excellent discussion. Are there any questions at all from the panel or chat?
So one from Simon Kendall again. A really interesting topic, thank you. Any knowledge of the impact on TAVR, or TAVI, as we say in Canada and probably the UK, on outcomes relative to surgical AVR?
Any
Sorry, any knowledge of the impact of TAVI versus surgical AVR on if you were to measure the same muscle density or mass on ultrasound and the other biomarkers of surgical versus TAVI patients?
No, we focus solely on surgical AVRs, and we wanted to be honest, we wanted to, because we're looking at some biological data as well, where we took muscle biopsies during theatre. We needed an insult of injury, which is normally caused by the sternotomy. So that's why we were focusing more on the surgical AVRs, due to the wideness of the project and the other things we're also looking at, which is why we didn't include TAVIs, because we needed that inflammatory stage in theatre.
Okay. Another one that's coming here from Evan Higgins. How does physiotherapy intervention affect outcome? Was the physio input considered in the rectus femoral result?
No, so we didn't do that. However, we at Barts, we are very lucky that patients receive a lot of hands-on physiotherapy, and especially after cardiac surgery. I mean, they try and sit the patients out very soon after their operations. We get them stable, and they do receive a lot of support. The caveat on that, though, is that one of the limitations for the study was that when patients went home, we were unable to see why some patients would waste more than others. And I think in the future, providing them with a stepometer or something to measure that would be useful, especially considering you get feedback from patients that some were very enjoyed going to cardiac rehab and were very for it. And there were some patients that considered it not enjoyable at all and didn't actually go to the extra classes. And so these are things we'd like to look on in the future, because there must have been an impact on that, definitely on the wastage of muscle.
If I could perhaps ask one more question with regards to your preoperative evaluation, really around the issues of nutrition and protein intake, both pre and post-operatively and upon discharge, how that may have impacted your patients, particularly from what I gather from my limited research in this area, is on leucine-rich proteins, where that might be protective against sarcopenia in the older adult.
Yeah, so there's a couple of things we did. The biological data that we're looking at, the muscle biopsies, we are looking at upregulated molecular mechanisms. But the other thing is we did bioelectrical impedance data, and that was to look at the amount of skeletal muscle mass they had before, so we could actually measure that. And interestingly, dry lean weight, which is the weight of muscle after water and organs are taken away from it, actually consistently successively decreased along with the muscle mass from the rectus femoris. So yeah, it's very interesting, and I think once we get in the lab and are able to look at these samples in further detail, it would be good to see why, because we had some patients that wasted more than others, and currently we're splitting the group into wasters versus non-wasters, because there were people that did waste considerably more muscle.
Great, thank you for that. Excellent.
Thank you, Ashley. If there's no more questions, we will. So the next presenter is Nicola Rea, and Nicola is going to present on the patient perspective of quality of life post transcatheter aortic valve replacement, or TAVI, and she's going to discuss the current knowledge base.
Hi everyone, thanks for joining me today to hear me talk about the patient perspective of quality of life post-TAVI and what the current knowledge base is. I'm Nicola Rea, and I'm a senior research nurse and staff nurse in cardiothoracics at the Royal Infirmary in Edinburgh. So the aim of this literature search was to identify the current knowledge base of quality of life following TAVI from the patient perspective. I used the Prisma flow diagram, as this provided a methodical and systematic way to identify all the current literature. It has 4 key aspects, including identification, screening, eligibility, and included. So I entered these key words and phrases in various combinations into Medline and Sinal databases, which derived 11 different articles. Then each of these 11 articles, the abstracts were screened for suitability, to answer the topic I was interested in. Of these 11, 6 were excluded for the following reasons. 2 of them focus on decision making prior to surgery. I was interested in quality of life post-surgery. 1 only included patients who suffered from delirium following surgical valve replacement rather than TAVI. 2 assessed cost effectiveness, and 1 explored patient perceptions, but not in the TAVI population. And finally, I included 5 in this as suitable in this search. 1, interestingly, was in mixed methods, which utilised both qualitative and quantitative aspects to inquiry. And then 4 were qualitative research inquiry, looking at in-depth patient experience. So overall, I found that there's definitely a paucity in research, where we definitely need more research on this phenomenon. From the patient perspective, 5 studies identified in this literature review used qualitative inquiry and provided a very different perspective, not usually captured by quantitative means. Whilst standardised questionnaires used in quantitative studies have a purpose and provide vital data for understanding quality of life, in an era where there's an emphasis on quality of life rather than prolonging life, we need an in-depth understanding of these patients' lived experiences, motivations, and perceptions of their health and recovery. The current research identified in this search highlights that patients want to live independently, autonomously, and without burdening their family. And beyond this, it's important to understand why some patients do not derive a quality of life improvement, which we can't get that understanding from structured, standardized questionnaires, which have been widely used to answer this question. We undoubtedly need more nursing research that is in depth on this phenomena to enable person-centered care. This is a very unique and complex group of patients, and further understanding is necessary. If we utilise this in-depth approach, we can work in partnership with patients to ensure their care is tailored to their needs. Happy to answer any questions you may have, and here is a list of references used to inform this presentation. Thank you.
Many thanks, Nicola, for that insightful presentation. It's very interesting to discuss quality of life in lots of the TAVI patients that we look after in the centre I work in are very old. We offer TAVIs to patients in their late 80s and 90s. So it's interesting to see that you would think that actually quality of life for them would be the key focus as opposed to maybe a quantity of life. But I suppose when you're that age, every year is another benefit, isn't it? Do you think that that has a factor, the age of the patients that were undergoing the TAVI? So obviously, if you had a younger cohort of patients, maybe you get a different outcome.
Yeah, undoubtedly. I think that is one of the sort of main motivations behind why I'm interested in this topic. I think their perceptions and outlook are possibly very different, and the research sort of alludes to that, but I guess it's still not fast enough to say that indefinitely. But I do think they are definitely a unique group of patients who I think to ensure they get the outcomes they want, it's something that needs explored further.
So there aren't any questions from Slido just yet, but perhaps again, if I could ask a question for you. So thanks very much for presentation. I really did enjoy it. For the health-related quality of life measures we use, and you may not know this question, I don't know that I know this answer to this question either, but are they adequately calibrated for the octo and nonagenarian? They're typically been tested on a younger group of older adults, if you will. Is it as relevant? Are the questions in terms of how we're gauging health-related quality of life in an 80 or 90-year-old adequate in the way we currently measure it?
Yeah, I think that's one of the downfalls of the way the sort of quantitative research has measured it to date. I think there's work going on for more sensitive quality of life questionnaires, but I don't think that they're not routinely used in the research that's been published to date. So yeah, that's a good question, and I guess one of the issues with the current knowledge that we have. Yeah, thank you
Great.
for your questions.
There is one question here again from Simon Kendall. Thank you again. So we need the data about quality of life post-SAVR and TAVI, as well as readmission clinical outcomes. His question is, do you think all aortic valve patients need a frailty score and a mini mental status exam to help us advise them on their best options?
Yeah, I would think so. I don't know if centres are routinely doing that, but I think that would be very useful in helping patients make that informed decision, and sort of, I guess, going back to person-centred care and involving them in these decisions as well.
Great.
Thank you for these questions. More questions, Nicola. I'd just like to thank you for your presentation.
Thank you.
So the next presenter, thank you.
Thank you for having me.
So we're going to talk to the next presenter, who is Samina Navana Low. And Savina is going to present on dental assessments for patients undergoing cardiac valve surgery.
Hello, my name is Samina Nayani Low. I'm a dental registrar in special care dentistry at King's College Hospital in London. Thank you for giving me the opportunity to discuss our recent service evaluation project entitled Dental Assessments for Patients Undergoing Cardiac Valve Surgery. I would like to begin by discussing the impact poor oral health can have on patients undergoing cardiac valve surgery, which I will now refer to as CVS. Poor oral health has been implicated as a risk factor for those undergoing CVS due to the risk of infective endocarditis. Several studies have indicated that oral microbial flora may play a role in the development of endocarditis, and that dental treatment to eliminate or control acute and chronic sources of infection may improve postoperative outcomes. Due to this, it is recommended that a dental assessment is carried out prior to CVS, and this is supported internationally by the European and American guidelines. However, there are no recommendations on how long before surgery this should be done. At present, in our service, referrals are made to the special care dentistry team once a plan for surgery has been confirmed. The referral is typically only requested for those who have not seen a dentist for 6 months or those who have an active dental issue. In this service evaluation project, we decided to review the current referral pathway for this cohort of patients, in particular exploring the timeline of referral to assessment to treatment, the level of dental treatment need, and whether referrals for dental assessments are causing delays in the provision of surgery. The data was collected prospectively over a period of 10 months from May 2019 to March 2020. 40 patients were referred, of which 80% were male and 20% female. The age range was 28 to 84 years old, and 53% were over the age of 65. Of the 40 patients referred, 39 were assessed as one was seen by another trust. 60% of referrals were made within 5 days of admission or transfer to King's, and 79% of patients were seen on the day of referral or day after referral, as illustrated here. All patients apart from one had their dental treatment within 1 week, and 74% had their treatment on the day of assessment. Most patients were referred with little time from referral to surgery due to the acute nature of their admission. 67% had provisional dates for surgery within 5 days of referral, and 23% were planned for imminent surgery, i.e. on the day, day after, or ASAP. In reality, as demonstrated here, 41% had their surgery within 5 days of referral. Lastly, most patients who did proceed to surgery did so within 1 week of having dental treatment, just under 80%. Only 18% of patients assessed did not require any form of dental treatment to be deemed dentally fit for surgery. The most common treatment required was dental extractions at 72%. Lastly, 43% of patients went ahead with surgery without delay. 18% of patients who did experience a delay were due to dental factors, and the reasons for this delay included 1 patient initially declining dental treatment and 5 patients who had referrals close to the time of surgery but required dental treatment, leading to a delay. Overall, once patients were referred for a dental assessment, appointments were arranged promptly. As found within the literature, there is a high level of dental treatment need in this cohort, which reinforces the need to involve dental professionals in the patient journey. Despite the urgent nature of the patient's admissions and need for surgery, referral for dental assessment did not often cause a delay with their surgery. However, 67% of patients referred had a provisional date for surgery within 5 days of the referral date. This resulted in most patients having their surgery very soon after dental treatment, typically within 5 days. There is debate in the literature regarding this issue, as ideally a period of healing of 10 to 14 days is required following dental extractions, because as with infected teeth, open wounds within the mouth can be a source of bacteremia at the time of surgery. So where do we go from here? To mitigate this issue locally, we are working on improving our referral pathway by developing an electronic referral form to support earlier referral and hopefully increase the time between dental treatment and surgery. We plan to carry out further research locally to review patients who have had dental treatment close to the time of surgery and the rates of infective endocarditis. Finally, further research is required on a large scale internationally to assess whether patients having dental treatment close to the time of surgery has an impact on postoperative outcomes. Thank you very much, and are there any questions?
There's nothing on Slido.
Yeah, sorry, there's a bit of a delay here for some reason. There are two questions from Slido. One from Sean Griffith. Have you the wonderful benefits firsthand of your dental assessment interventions over the past few years for valve patients and expediting surgery? Do you plan to expand this initiative to elective valve patients prior to surgery?
Sorry, I think there's a bit of a delay, so it was a bit crackly. I couldn't.
I'm sorry. Let me try again. Is that better?
That's
okay,
clearer.
perfect.
Thank you.
All right. I'll distill it to the last part for Sean Griffiths here. Do you plan to expand this initiative to elective valve patients prior to surgery?
So that is something that we're looking at with our cardiothoracic colleagues, with a plan potentially of introducing a dedicated cardiac dental MDT clinic. We have a similar setup with other specialties, mostly with oncology, where we carry out dental care for their patients. So we're potentially looking at doing something for the elective cardiac patients, because I think in general practice, a lot of dentists don't fully appreciate the impact that dental health can have on their surgery and their outcomes. And we may be better placed to advise patients on their risks and what treatment they may require.
Excellent. Another question here from Hannah Moore, very topical related to COVID. Because of the delays and people seeking dental health care over the past year due to the pandemic, they're seeing delays in surgery due to waiting for these assessments. Do you have any suggestions on how we overcome this?
So I know there has been an issue, and I actually saw there was another abstract in this conference where I think another team had been looking at whether the rates of infective endocarditis had increased. And I think they found that it hadn't. But I know locally patients have struggled. We've been able to help, fortunately, because our elective lists were cancelled. We were actually available to help the cardiac team see some of their elective patients. So we've been able to help where usually we would only see the acute admissions. We've been able to help. Most hospitals do have oral and maxillofacial surgery teams who sometimes can assist with doing dental assessments, as they are dentally qualified and they could carry out some simple treatment like dental extraction. So that might be an alternative to approach them.
Excellent. One last one here, and I'm going to claim my Canadian ignorance on the term OPG, but from Tara Bartley. Did referrals require an OPG to be completed, as this would have saved time for your team?
Yes, so an OPG is a dental x-ray, and we ask our cardiac team to arrange one of the x-rays prior to sending the referral. If they request the x-ray at the time of the referral, hopefully by the patient gets to our clinic, they've had the x-ray taken. So that just speeds up our assessment and the consent process. But we're fortunate we have x-ray machines in our surgery, so we can always take additional images if we need them on site.
Excellent. Very good. Thank you.
Great. Thank you very much.
That's great. Thank you for those, Rakesh. I just wanted to ask you a question. So I deal with, I work with pre-assessment clinic and pre-operative assessment for all our patients in Southampton. We unfortunately don't have a dental service in our hospital at all. We did, and the dentist retired, and therefore we have to beg and plead. A lot of our district general hospitals, they have the same system. They don't have access to dental at all. So we've had to change and basically, assess the patients, discuss with them if they regularly go to the dentist, have they got any issues, sort of impress on them that after surgery, they then need to, make sure they go to the dentist if they have any pain, swelling, any abscesses. But obviously, that's a major impact that we have on all the patients on the South Coast where, dental provision, unfortunately, not as easy as we can get to. What sort of impact do you think that would have on the patients? Because without having access to max fax in the hospital, unless somebody comes in with actual pain, do you think long term that would have a major impact, or do you think that we're doing something that we can?
I mean, it sounds like you're doing what you can with the resources that you have, but ideally, if you look at the guidelines, be it the European ones, the American ones, they all do outline involvement of a dental professional. So we're trying to ensure that there are links there throughout the patient journey. Although I said that some dentists in practice may not understand or appreciate the impact, it is something that's routinely talked about in dental school and in our literature. So dentists should be aware of the impact and the risk of infective endocarditis. And there are resources available online for patient information leaflets as well, which could be shared by yourselves. Our specialty, special care dentistry, is available sort of nationally, and we deal specifically with medically compromised patients. So it could be worthwhile getting in touch with your local special care dentistry team to see if you could forge some links there. But really, it's just making sure the patient's informed and aware of which symptoms to look out for, and then to seek the appropriate help. I don't really know what else could be done other than have a dentist.
I write down special care industry, because we have many patients who, especially with COVID, the dentists have been closed. We have many patients that ring us all the time saying they haven't got a dentist. They're trying to find a dentist in the community. And obviously, we say, look at 111. We give them tips. They ring dentists who are not taking on NHS patients. So anything great. Thank you for that little tip. I'm writing it down.
Thank you.
It's marvelous. If we haven't got any more questions, that's great, Samina. Many thanks for that presentation.
Thank you so much. Take care.
Thank you. So the next presentation is from Catherine Hewitt. Catherine is going to present on the Wolverhampton Infection WIPS project, and she's going to present on her 1-year data. Welcome, Catherine.
Hello and welcome to my talk today on the Wolverhampton Infection Prevention SOP, which is our 1-year data. I'd like to start by thanking you all for being here today, and also for the Society for the opportunity to be able to talk to you today. So back in 2018, we completed the One Together toolkit, which identified areas of the patient pathway where we can improve on our surgical site infections. We then did a retrospective audit of all patients undergoing cardiac surgery in 2017 and identified that our surgical site infection was around 9%. And this was based on 800 cardiac surgical cases. A key point that we identified is that 60% of wound infections were identified after day 10 post-op. So we put some interventions into place to try and help reduce this. The first thing that we did was to identify a surgical site infection multidisciplinary working group, which was key. We then formulated a wound care guide for patient empowerment. We utilised the Brompton Harefield infection risk assessment score to risk assess our patients on admission. We then put in place a bundle approach for each patient depending on which score they were put into. And the changes that we made, for example, looked at the use of negative pressure wound therapy, whether we used double wires intraoperatively, collar tamp, whether EVH was a better option for these patients, and things like post-op bras and post-thorax jackets. The final thing we then did was to identify and to utilise photo at discharge. Following these interventions, we did a prospective data collection of all consecutive patients undergoing cardiac surgery over a 12-month period. And we looked at things like the type of surgical site infection, the organism grown, the point of detection, whether there were MRSA and MSSA, and basically whether the protocol was followed. We also were able, utilising the photo discharge, were able to identify whether there were any concerns at the point of discharge. The results showed that back in 2019, we did 914 cardiac cases, and we identified around 36 surgical site infections, and only 3 of which were deep surgical site infections as classified by Public Health England. So therefore, we identified a reduction in surgical site infection from 9% to 3%. Again, the point of detection was as an outpatient or as a readmission with a surgical site infection, with only 5% of these SSIs being identified as inpatients. Again, the BIS score was very mixed. However, we did identify a reduced high score on admission. Therefore, we showed that the interventions did have, in fact, reduced the surgical site infection within this group. We did identify that around 30% of our patients screened MSSA positive on admission, and this is quite important as our results then showed a Staphylococcus aureus was our greatest organism that we grew from our SSIs. So of the surgical site infections, 1% were graft site, and of these patients, 77% were open harvest, with only 23 being EVH. Therefore showing that EVH has, as we all know, a lower surgical site infection. So therefore, not only did we identify a reduction in cardiac surgical site infections, we also reduced the financial burden of surgical site infection for the trust. We showed that a multidisciplinary approach and buy-in was imperative to be able to empower the team to create this change. We also showed that patient and photo at discharge and wound care guides improved patient empowerment and therefore improved morbidity and mortality. Thank you.
Catherine, that's a great presentation, and I'd just like to see if I could open up the question to the panel or to the chat, and anybody in Slido.
I'd like to ask Catherine a question, actually. I work in Wolverhampton, and this is a bundle that we kind of use on a daily basis. So I just wondered whether you have an idea of the sort of the compliance rate for the bundle, or is it still dependent on what the surgeon thinks should be used for the patient?
Yeah, thank you, Jenny. I just want to point out, as Jenny says, Jenny works as an SEP at Wolverhampton, and I currently don't work in Wolverhampton anymore. This is data that I collected when I still worked there, and I've been in touch with the team there since I left. So I do feel that I can answer this question, but obviously in terms of compliance, whilst during our first year of data, we showed actually very good compliance, which was presented in the presentation just now. But however, we have noticed over the last year with COVID and all the other bits and pieces that have been happening in centres all across the world, really, compliance has obviously been challenged. and alongside that, I just want to try and explain a little bit. At the very beginning, when you start any kind of project, to get complete buy-in from every surgeon is almost impossible. We met with a lot of challenges, and these were overcome over time. Different ideas on what dressings were better for the patients, different experiences from different centres that had been worked in previously before. And naturally, we ended up with a lot of challenge, and challenge is a good thing because it makes people talk about it. So that is there. That is always going to be there, but definitely, I would say it took about 3 months to get over that. And then certainly for the latter part of the data collection, that definitely improved.
Thank you.
We have 2 questions from Slido here. 3 now. First one from Helen Monday. Well done, Catherine. At Barts, we have seen a significant reduction in SSI rates during the pandemic. Is this something you or others have seen?
So in terms of over the last year, so again, just to explain, over the last year, I've been working at the Queen Elizabeth Hospital in Birmingham. So my experience over the last year will be from that centre itself. I don't know whether Jenny is happy to express anything from Wolverhampton itself. But I think in terms of surgical site infections, it's very difficult to be able to quantify what is relevant and what is actually applicable to the service. I know certainly at the QE we've been stung quite heavily with COVID, and we've not managed to push through as many patients electively or as emergencies over the last year as we would have liked to. So I think it would be very difficult to comment on the rates of surgical site infections over the last year. Ourselves at the QE, we are including ourselves into the big research study that's now being presented with the CIRN within SETS and the Research Institute to look at our surgical site infections. We're a little bit less fortunate at the Queen Elizabeth in comparison to Wolverhampton, in that Wolverhampton have a fantastic surgical site surveillance team that sits within the trust who monitor surgical site infections across all specialities. And this gets automatically reported back to each speciality down to a fine tooth comb, so even down to surgeon specific. So that is really, really good way of being able to monitor surgical site infections. Unfortunately, at the Queen Elizabeth, we don't do that. And I wasn't quite aware that involvement in Public Health England and reporting of surgical site infections wasn't mandatory. So that's something that we've found a real challenge since I've been at the Queen Elizabeth, and it's something that we're looking into moving forward.
Okay.
Thank you very much, Catherine. I think I would have to say that the implementation of your bundle has definitely helped reduce our infection rate in Wolverhampton. And thank you for your presentation.
Thank you.
If we have time, I have another couple quick questions here.
Yeah.
One from Rosalie Magbu. How do you maintain the sustainability of the project?
Yeah, so I would say creating a good multidisciplinary approach. So our first approach was to create a working group of people from all the different areas of the patient pathway to create buy-in. So as soon as people get talking about surgical site infections, as soon as that became a thing that we were talking about, looking at retrospectively, we automatically saw our surgical site infections reduce. And that's just because of creating awareness. People are suddenly more interested, more aware of how they are treating wounds and how they are looking at patients throughout the whole pathway. So in terms of that, like I say, it's creating these key people within each section to make sure that that is continued and they are continually pushing through. I would say while I was at Wolverhampton, and I know it's quite difficult because the last year face-to-face governance meetings have definitely been withheld. However, for the first year of our project, we did monthly feedback through our clinical governance, where we reported back on a monthly basis what our surgical site infection rate was, how many infections we'd seen, and I think that again created a lot of awareness. And that's a multidisciplinary approach. And I think in order to create that sustainability, it's the key is to keep people interested and to keep reminding people that this is still happening. This is still something that's going on. Yes, we've done a fantastic job to be able to reduce our surgical site infections. However, it's still ongoing.
Okay, I know we're out of time, but there's a nice question from Uday Trivedi that perhaps you could type your response in the Slido as well for him about how you picked these infections up earlier. So thanks very much.
Okay, thank you.
Thank you, Catherine. That was a great presentation and questions. The next presenter is Sandeep Singh. Sandeep's going to present on improving interpretation of coronary angiography, a pilot quality improvement project.
Hello everyone. Thank you SCTS for endorsing us to present our quality improvement project. My name is Sandeep Singh and I'll be presenting alongside my colleagues Dr. Ramesh Tiramana and Dr. Ahmed Hussain. I'd also like to thank Kirandeep Kaur Singh for digital illustrations for the coronary angiogram guide. This quality improvement project is about improving the interpretation of angiograms. We wanted to create a guide that was easily accessible as a tool to empower all allied healthcare professionals to utilize during theatre time or wartime to look at angiograms and easily interpret the vessels. We understand that this can vary with great difficulties, and so we set out to have a brief snapshot of our guide to see whether it produced any good results. I'll pass on to Ramesh Tiramana to discuss the methods.
Thank you, Dr. Singh. So this quality improvement project recruited 11 foundation year doctors. We then compiled a set of anonymized patient angiogram images to form a pre-guide test, which we sent out to each candidate using Google Forms. We then provided the angiogram guide, as mentioned, with 3 days to learn and study. After this, we used the same images from the pre-guide test to send out a test afterwards as well. And then we analyzed this data. Here you can see an example of one of the questions we used, illustrating the right coronary artery. The candidate is asked to label the vessel of focus, as I said, the right coronary artery, and then also the branches from 1 to 4 as labeled here. Thank you. I'm going to pass back to Dr. Sandeep Singh.
Thank you. So this is essentially showing images from our guide. It starts off with text about the cath lab and about the coronary arteries. It then shows images of the heart in different orientations with the coronary arteries embedded. And then we go into a focus view about each of the angiogram and each of their views. We discuss in a snapshot the key vessels and branches, and then talk a bit about what the importance of each orientation. And here you can see the right coronary, and here you can see the left coronary. Pass back to Dr. Ramesh Tiramana to discuss the results of our project.
Thank you. The results showed a significant improvement in the score on the angiogram interpretation test with a p-value as shown. Parallel to this, the confidence was also improved for the cohort on average. And these further illustrations show the individual candidate score and confidence pre and post guide. The blue bar is the score and confidence before the guide, and the orange bar shows the score after the guide. As you can see, there are some bars which don't have an orange bar next to them, and this is because we recruited 11 foundation year doctors, and 6 of these went on to complete the second round of the study, which was the second post-test. Thank you very much. I'm going to pass on to Dr. Ahmed Hussain.
Thank you, guys. So what can we conclude from all of this? Anecdotally, we know that some team members, including junior doctors and allied healthcare professionals, generally have a bit of trouble reading angiograms. After introducing the angiogram guide and the teaching session, There was an overall improvement in the self-reported confidence, and there was a statistically significant increase in the test score as well. This is important because angiogram interpretation is a key skill in cardiology and cardiothoracic surgery. Allied healthcare professionals, they've expressed an interest in our guide, saying that it can help them make better care decisions. What we want to do going forward is actually make our guide more widely available. We've been endorsed by the BSUH medical education team to turn our guide into a standalone e-learning module with yearly certification. Cardiology have reviewed the guide, and we're just waiting for final approval by the cardiothoracic surgeons at this point. Once we've introduced it as an e-learning module at a trust level, we plan on re-auditing in about a year's time with a larger sample size. That's the end of the presentation. Thank you very much for listening. Our email addresses are here at the bottom. If any of you guys want to get in touch with us, because we're more than happy to share our guide to anybody who's interested. Thank you very much. We look forward to meeting you in the live Q&A session now.
You for the presentation. That's a great guide. Obviously, you're talking to a wide audience of AHPs, nurses, allied health professionals. You know, all of us have got a major interest in looking after patients who are undergoing cardiac surgery, and angiogram interpretation is one of those things that, you know, is key really to a lot of the patient care that we give. So I think everyone's going to be emailing you after the end of this presentation saying, how do we get hold of this guide? Is it something that we can you can roll out to AHPs, advanced nurse practitioners across the country, really, so that we can increase our knowledge and skills in looking at the angiogram? Is that something, do you think, that you'll be able to do in the future?
Sorry, I don't know if you can hear me now.
Yeah, we can.
So actually that was one of our things that we were interested in doing. So one of the things that we actually got feedback when we did the written guide was, can we make it a bit more interactive? Can we make it easier to use? And so because we're now putting it as an e-learning module on our trust, we're going to firstly roll it out to the Brighton and Sussex staff initially. And we're going to try getting a bit of feedback from them as well to see what sort of further improvements that you can make, because it's very easy to just copy and paste from a Word document or a PDF without actually thinking about how do we make it work on a tablet or a phone or a computer. So once we've kind of sort of done it with those guys at a local level, we do plan on sort of expanding it more nationally and putting it on ELFH. And when we've been developing the guide with the input of our IT team, and that was something that we made quite clear to them at the beginning, that we do want to, not restrict it to one region or one place, because ultimately it is something that, can help, a lot of people across the country in improving their skills. It was definitely something that myself and Ramesh struggled with a lot at the beginning. We found that having this guide helped us as well. So we thought, why not make it more widely available?
Yeah, that's great. That would be really useful, because I think there's lots of nurses, allied health professionals who nurses on the wards as well, who are looking after patients and actually, don't fully understand exactly the role of the angiogram and know exactly what's going on, or as a refresher, just to keep up to date with what's happening. If you're not working in a cath lab, it's very easy to sort of lose all those skills. So that would be something that would be very useful. Are there any questions at all from Slido? I think there are. I think you've been let off the hook here, guys.
That's good. I just want to add that we can give out a sample of the guide, because we have actually developed the module and it's all working. It's going to be live shortly in a few days. So anyone that's interested, the email addresses are there, or you can contact SCTS, and we're happy to give out the samples so that everyone can have a look and see what it's like.
That's fantastic. Everyone's writing your addresses down now quickly. Anyway, many thanks for the presentation.
Thank you.
Thank you.
Thank you.
So we'll move on to the next presenter now. The next presenter is Bindya Nair, presenting on a retrospective study investigating the prescribing practice of non-medical prescribing with medical prescribers within the cardiothoracic specialty. Welcome. Do we have our next presenter? I think I jinxed it by saying that we were doing so well with all the presentations. Oh, here we go.
Hello, my name is Amy Chadwick and I'm the lead occupational therapist at the Royal Papworth Hospital. A multi-professional team have been working on a project around frailty. We wanted to better understand whether the assessment of frailty would provide improved decision-making and outcome in patients undergoing cardiac surgery. Many patients referred and accepted for cardiac surgery have clinical frailty. This is even more so in the case of the non-elective cohort of patients that we see. Frailty can either be related to their current disease process or chronic related to their comorbid disease state. A clinical frailty score can assist in understanding a patient's clinical status, their ability to withstand a big operation and the recovery that is required afterwards. Factors included are patient's mobility, strength, support network, mental cognitive health, and their emotional resilience. An analysis of hospital frailty risk score against clinical frailty score within cardiac surgery was undertaken by NHS England in 2020. They report that length of stay rises with increasing frailty, that severely frail elective patients stay 3 times as long as mildly frail, and the likelihood of cancellation increases with frailty. Since 2018, we've been working alongside the Specialist Clinical Frailty Network to review the way we assess and manage frailty within our TAVI, in-house urgent and elective cardiac surgery pathways. We assembled a multidisciplinary team of practitioners led by a nurse consultant and consultant anaesthetist and used quality improvement methodology to consider whether frailty assessment using the Rockwood Clinical Frailty Score would improve identification of patients with frailty. Firstly, we collected baseline data. We added the Rockwood Frailty Score onto our EMR and communicated this out to all clinical teams, requesting that all patients admitted to the hospital should have a clinical frailty score undertaken. The first table shows compliance with the use of the Rockwood Frailty Score in 2020. The second chart shows frailty scores of patients admitted for elective cardiac surgery. You will see that most patients score 1 to 3, with about 20% admitted with a score of 4 to 9. The following bar chart again shows the distribution of frailty across our patient group. The last bar chart shows discharge destination, and as you can see, most of our patients are discharged home. We undertook an analysis of 15 patient journeys to understand the time taken in our current pathway between first referral and post-operative follow-up. This clearly showed delays in the front end of our pathway, mainly in the initial stages from referral to surgical pre-admission clinic. This clearly shows we have enough time within the current pathway to provide pre-optimization prior to surgery. During the pilot phase of our project, 94 patients were referred to the frailty team and 79 underwent some form of surgery. The pilot study data shows that 60% of patients referred to the frailty team had a score of 4 and 30% had a score of 5 or 6. This table shows the number and type of interventions that were provided to the patients as part of their preoperative optimization within the project phase. We think that patients with a clinical frailty score of 4 or more would benefit from enhanced preparation for surgery, and those who have a clinical frailty score of 5 or more, if they had a comprehensive geriatric assessment, then this would help aid clinical decision-making and impact on length of stay. We've proposed a further 6-month pilot phase and implementation of a frailty team where robust outcome data will be collected by each of our specialist support teams. So what is prehabilitation? From a cardiac perspective, prehabilitation is essentially a proactive version of cardiac rehabilitation. It can be a combination of exercise training, education, social support, and other interventions which aim to optimize functional reserve, status, and cognition, as we know that major cardiac surgery places a huge stress on the body, and even more so on our frail patients. Moving on to the evidence around cardiac prehabilitation, there was a systematic review and meta-analysis completed in 2018, which looked at the impact of prehabilitation on post-surgical complications in patients undergoing non-urgent cardiovascular intervention. These range from 6 to 12 weeks in length, and this slide shows the positive effects that prehab programs can have on cardiac patients. There are clear limitations to the evidence surrounding cardiac prehabilitation, such as small sample sizes, and the range of interventions were not comprehensively evaluated and mostly were focused on the physical aspects of recovery. Therefore, this paves the way for our team at the Royal Papworth Hospital to trial our own holistic prehabilitation programme, which has the potential to transform perioperative care. We feel that when we put these elements together, they could have a synergistic effect which reflects the complexity of recovery. There is increasing evidence that social isolation and loneliness from COVID-19 is having profound effects on people's physical and mental health, especially those waiting for surgery. This means that it's even more pressing that we assess patients holistically pre-surgery. Thank you for listening.
Presentation. My apologies. The person before, unfortunately, is cancelled, so was unable to present. So Amy has stepped up in her place, which is great. Amy, fantastic presentation. COVID definitely has, we've seen, has had an impact on patients waiting for heart surgery and thoracic surgery. Do you think this is something that you could create on an app or something that, you know, patients could be using and whilst they're at home before they come in for their surgery?
Yeah, definitely. I think if we were able to sort of have contact with them before they came in for surgery, we could certainly sort of signpost them onto sort of different resources that they could use to sort of help with their mental as well as their sort of physical well-being. Definitely.
I think we've got one question from Mr. Simon Kendall. Good work. Which frailty scores would you recommend we might consider using routinely?
Yeah, so we use the Rockwood Frailty score, which seems to be sort of quite well used, and we found that to be really effective in sort of identifying frailty.
That's good. I don't think we have any more questions in the Slido. Any more from our panel?
That's great, Amy. Thank you very much for your presentation. Thank you.
Thank you.
So Amy was the last presenter in this session. So we have finished a little bit before time, which is nice for a change, rather we're running over. So I just wanted to thank all the presenters for their fantastic presentations. I'd also like to thank my co-chairs, Jenny and Rakesh, who's obviously disappeared off to another session. I think he's a man in the
in demand.
Want. So I'd also like to thank the SCTS for letting us chair the session and to give all the presenters the experience, and our sponsors, our Consent of Patients. We'd like to also thank them for sponsoring this informative session. The next session is this afternoon is starting at 3:30, so you've got a little time for a walkabout and to get a cup of coffee before the next session starts at 3:30, and that's looking at advancing roles and evolving services. So please do come back for that session, and please also go into the virtual exhibition hall and have a look around there as well. That would be great. Anyway, many thanks for everybody. Take care.
Thank you.
Thank you.